Greetings and welcome everyone to another episode of Oral Pathology 360. Today's topic is very interesting and it's not really discussed much, so it will be great. And we are sort of going to be looking through the topic probably among the first times, at least as far as diagnostics goes, in a roundtable. Now, let me just say that if you are here for the first time, please hit the subscribe button. This channel is all about oral pathology, oral medicine, head and neck pathology, and of course, at times, oral surgery. Now, sometime back we announced a membership, and I am happy to say we have our first Maestro member. You can also join and become a member. The join button is just below the video, and it's just gives you a number of perks for a small contribution every month, but helps us to do more and start with new activities and new things, including a video atlas of clinico-pathological video atlas. So that is something we are really looking forward and working on very hard. So coming to today's event, let me bring everybody in. Right, with us we have Dr. Roshan Chanoy from Mumbai. She's a pathologist. We have Dr. Jose Amenabar from Brazil. He is an oral medicine specialist. We have Dr. Shubharni from India. He's an oral surgeon. I'm sorry to tell everyone that Dr. Ranganathan could not make it because, as you know, there is a storm going on in Chennai and their power and internet is down. He sends his apologies and we will definitely miss him. Now, to just give a little background to this topic before we go any further, what I found is that while I was researching, of course, every topic one has to research it before going on, the attitude that comes across as far as patient safety goes is like it's done and dusted. It's like everything we find now online is about patient communication and involvement of patients in the whole treatment process, including of course diagnostics. And while that is very important, it's not the only thing. We are not really done with everything else. And the proof for that is that the WHO found 43 million patient safety incidences occur each year. That's 1 in 10 patients are harmed while receiving treatment. This is a WHO statistic. Now, a quarter of a century after the first report by the US Institute of Medicine, who, in their very interesting report titled To Err is Human about patient safety, came out and for the first time said what was happening. That was 1999. So, not much has happened, and the numbers are still very high. Now, the Institute of Medicine at that point defined patient safety as the prevention of harm to patients. But the more recent definition, which I believe is more practical, is the absence of preventable harm to a patient and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. Because, of course, as we know, there are certain things which have their own inherent risk and harm. Now, drawing from this, we can say that there are issues that relate to errors are quite a few and don't include only errors, but of course include the limitations of the tests and the inherent harm that they may cause. Medical records have found that there are, I am sorry, yeah, some 6 to 17% of all the adverse events in hospitals are due to diagnostic errors. Now, this includes wrong, missed, and delayed diagnosis. To put this into perspective, if you do a back of envelope calculation, this percentage translates to 2.58, extending to 7.31 million patient safety incidents in diagnostics. Now, the diagnosis cycle begins and ends in the clinic, starting with ordering of the test, to conducting and reporting the tests, and finally appropriately interpreting and reacting on these. The parts of the cycle are termed as pre analytical, analytical, and post analytical stages, and errors, of course, can occur at any part of the cycle. In the healthcare system, lab medicine and imaging has always been considered low risk. Of course, because there is not much subjectivity. For most things, we have standard procedures. There's a specific way to do a test, and there's a specific way to expose an X-ray or do an MRI or a CT. There are not many. There's not much subjectivity. There's not many ways you can do it. So, because of that, it's always been considered that we are on the lower risk end of the whole spectrum of patient care. And there are very, very few publications on this. There are few, that is recent publications. Old publications were there on lab errors and just a couple on imaging errors. But it has been reported that the prevalence of lab tests or errors can be as high as 1 in every 900 to 2074 patients. The maximum amount of errors right now is in the clinical interface, as reported, that is in the pre and the post analytical phase. But nonetheless, of course, there is also in the analytical phase. Now, sadly, I could not get a oral and maxillofacial radiologist or a radiologist with us. But I think we are anyway not even going to talk about the lab tests individually. We are going to be generalizing. And we have got a background set up. So this is going to be a roundtable with each question. We have a set of questions with each question will be in the first round. I request our participants to answer in a very brief, just 30 seconds, and then we will go back to everybody's answer and have a discussion. It is an informal discussion, it's not a panel. Also, we will expect and request all our audience also to take part simultaneously. So, with this, yes, now, right, let's get on with it. Let me again say hello and welcome. I know you all have been waiting patiently for me to finish talking. Sorry that took long. Yes, you are all live, by the way, just to tell you. So, right. Can I not hear you all?
Yeah, I can
You
hear you
haven't
clearly.
spoken yet.
Yeah, we can hear you.
Yeah, okay. Everyone
Yeah,
is
I
fine.
can
Yeah,
hear
all
you.
right. Okay,
Yeah,
cool.
yeah.
So, let's go with the first question then. Right. What was our first question? I'm sorry. Yes. So, our first question, what we are going to talk about is from your experiences, what are the examples of skill based errors? Of course, now we know that errors can be different types. They can be skill, they can be communication, they can be acts of omission and commission, or what we say intention and attention. And so, what do you think is the one among these? In the skill based, we'll go with skill based first. So, among these, which have you encountered in the diagnostic cycle most? And how would you think they influence patient safety? So, let's just go around with this and let me just put this here right. Okay, so let's go with Dr. Roshan first. What do you think?
By skill based, I expect you mean technical skills uh,
Yes, it could be
or
technical,
starting
yes.
from the beginning,
Starting from the
receiving of
beginning would be good
samples.
because that is also skill. Yes,
Yeah. So getting samples, we have problems sometimes if the sample comes at night or it's lying in the lab which is unattended or it is coming in saline instead of a formalin. It's not coming in the right medium. So these are the beginning problems. And one big problem we face is that the requisition form is often inadequate, not filled completely, or sometimes wrongly filled. So, beginning with the sample and the requisition form, I think we have to start there, seeing what are the errors we face. In our labs, we do face this, though we have a strong and robust SOP, but still there are lapses in this at times.
right. So
You want
basically, Yes, let's go with Professor
Sample
Hossein now.
collection.
Sample collection, yes.
Well, hello everybody. Thank you very much to Dr. Mandana for the invitation. It is a pleasure to be here again with Dr. Roshan and
My
Dr.
pleasure.
Shiva. And I think one of the uh, main problem probably it will be the inadequate sample collection. You know, incomplete or incorrect samples may result in inaccurate diagnosis, and this would lead to inappropriate treatment and sometimes compromising patient safety. So I think that will be one skill-based error. Maybe another error could be misinterpretation of the imaging results also, because this can lead to incorrect treatment plans. And another one could be improper execution of diagnostic procedures, like poorly performed procedures can lead to complications such as infections or injuries for our patients.
Okay. So, yes, Dr. Shivbarni, what do you think?
Ma'am, good evening all. Very happy to see you after many, I would say years. Downgrade. Happy to, very thankful that you called me onto this platform. Ma'am, coming to the discussion, you asked that about the skill-based errors. I think it is totally individual perspective. That means to say that everyone faces a different problems depending on the conditions, circumstances in which they are working usually. So, for example, when we both are working here, we had our own problems of collecting the sample, sending to your lab. Uh, so, main thing, when what I felt in my little experience is like the lack of uh, obtaining the proper patient history first, and improper communication with the radiologist and the pathologist. Uh, and what kind of diagnostic procedure that we're going to perform. So some lesions may need FNAC, some lesions may need biopsy. So some lesions may not need anything, only radiological diagnosis. So this is where usually we face the problems in the initial phases of establishing the diagnosis. So skill-based errors on the search side also like an inadequate sample. And what Madam rightly projected that sending the specimen in saline instead of sending in 10% formalin. So it happened even after you left from here. We had few cases where youngsters they don't know. They just put the sample in the saline. They keep overnight. The pathology lab is not open. Next morning when they send the specimen to the pathology lab in the saline, it's already gone. Tissues are not fixed. So, so this is a common error which I have seen in my practice.
Right. Yes, very correct. So basically, we came down to the starting from the right choice of a test, the appropriate choice for the test, the appropriate way of collecting it, or that is, of course, in pathology. In radiology, that would be different. And then all the normal things like the identification, the procedure, and so amongst these, I mean, like now Dr. Shubhani said, he's come across the inappropriate fixation,
Yes.
right? So, and I know and I remember from when I was there, and this seems like it shouldn't happen, but this is where you have the miscellaneous, is where things go missing, miscellaneous errors. It's not skill, it's not really skill. This is where you just
Mm.
sort of people forget things. And I think even what do you think an error of say sample collection in terms of how it is stored or transported, is it really is it possible that there are people whose skill is still not there, or is it just a matter of it becoming an act of omission rather where they just basically forget.
But basically, it is negligence, ma'am.
Negligence, yes, okay.
It's definitely
So
negligence because
negligence.
it's a basic thing, right? We don't need any skill for that to understand.
That's true.
And you need training. You need to train even the
Yes.
unskilled people to go through a right path.
Yes, that is true. You know,
And
the
I think we can prevent that using maybe some checklist and
yes,
some standardized protocols.
that is true. I think a checklist, yeah. That is very, because of course, again, like I said, I mean, possibly say when I think of it, or anyone senior thinks of it, it seems impossible that someone would not know certain things. But in reality, that's not true. We have juniors who will obviously not know until we teach them and until they learn. Yes, so that is true. What else do you think in the skill? Now, I think on skill, one of the things we have a lot now is technology. So, what do you think? I mean, how fast can we update, or are we supposed to update, or how do we update everybody, say, in a department or in a unit, of the latest equipment that's arrived? Because with today's technology moving so fast, it's actually a big problem. So I mean, like, what are the steps you all take? Because I have noticed, like, in a hospital where a certain thing was being used in the presence of the patient, they are deciding, okay, let's read the manual and know how to do it. So this is a little not appropriate, I would say, or maybe a lot not appropriate. So what do you all think? How do we overcome those situations?
I think we need to do
Yeah,
regular
definitely.
training and skill assessments, like continuous professional development. And everybody needs to be like a little bit humble and realize that we all need to learn. So
Yes,
I think it would be like that.
right.
When
I
there's
think
a
we need
new
to do the
equipment
skill-based
brought in,
programs, ma'am.
sorry,
Yes, Dr.
Please
Roshan.
carry, ma'am.
sorry. I said when we have a new equipment brought into the hospital or in the lab, then the vendors usually come and give us a demonstration and give us a small route of how to go about using that instrument. That does help because then we have a little SOP with the new equipment and we try it out before we actually put it in motion with the patients.
Yes. And what about, I mean, like, updating everyone? A part of,
Yes,
there are errors, especially I think in the lab in pathology, where we come across where you cannot be 100% sure that it is an error, because it is within a range. But like, for example, if we don't, do the
calibrate.
yeah, do the quality assessment or validate the test often enough. So how can we overcome those?
Well,
Any
if you're
suggestions?
thinking of validating tests like IHC or uh, uh, correlation between FNAC and histopath or a frozen section and the final, those audits are kept as records. And periodically, we are supposed to do audits of this. It brings out things which we've skipped or ignored. So that these audits do help. Even small audits over a period of few months, it helps us to pin down where we are really missing things.
Right. So I think, and not just pathology, probably anywhere, if we can, if everyone becomes, regularly decides to report errors, first record them and then report them and discuss them. That could be a way of
Yes.
overcoming all skill problems. Let me see what the
So we
audience
do
has
have
to
Important,
say.
SOP
madam.
books.
Yes, please go on.
Oh, We have recording of reports where we've missed the boat or we've had an error and we document it. That I'm so afraid sometimes if we slip doing it, but it's a helpful exercise in the long run.
True. Let's see if our audience has anything to say. I'm going to request the audience, please, as usual, put in your thoughts and questions as we go in. Um, Today, we will not have questions only at the end. We will have it as we go along because of, anyway, the whole format is questions. So, yes. Okay. So, basically, we could think about some skill based errors. One was in the sample collection, one was in the
Just put the
identification, one was
question on.
in the procedural
The
way, or not knowing what tests need to be done. And I think the last point, that the error reporting, because finally, like that paper said, to err is human. So error
um,
reporting is what will then be able to help us to come back.
it,
Yeah, what I was reading is, I think the NHS has certain events which they consider as never events, and those have to never happen. And if they do, they have to be reported. So, do you know of
okay.
anything like that within the diagnostics chain, which should be a never event, or which you think should be a never event? I mean, like in dentistry, extraction of a wrong tooth is a never event. To give you an example, if you extract the wrong tooth, is a never event. It should never happen. Yes, there is no excuse in that. So, can you think of anything in the diagnostic chain, starting from the clinic back to the clinic, that should be a never event?
I think maybe data entry mistakes and sample mix-up.
Hmm.
Take a sample and get to the lab another sample from another patient and it got mixed up.
Yes. In
There's a
fact,
lot
this is
of
something
echo,
Dr. Roshan
Mandana.
was telling us a lot. Sorry?
There's a lot of echo.
There's a lot of echo. That that
A lot of
is
echo is there.
okay. Sorry. That is part of it is my problem. Okay. Okay. Is it gone?
Yes, when you speak,
Okay.
it's gone.
Yes.
Okay. Sorry. I seem to have a little problem with my various earphones. Okay. Right. So, okay. Now it's better. We shall go on. Okay. We were talking about never events. Now, like you said, mislabeling a sample, and sometimes it cannot be helped. I mean, it's not that, I'm sorry, it's not that it cannot be helped. It can be difficult to avoid if we don't follow certain standards. And I think mislabeling, or basically wrong patient, or misidentifying a patient and thereby the samples, is one of the 10 main recognized problems of diagnostic of error, patient safety situations and errors. But you know what? Dr. Roshan and I were just talking the other day, and like she said, in her place of practice, a lot of patients are all called Muhammad. So if the names are common, then you have to be very, very careful.
Yeah, we have
And yes,
almost every alternate patient is Muhammad.
yes. And it all depends on where you are and what you do. It's like, I would say, like right now itself, on my phone, among my contacts, there are three Dr. Satish Patils, and they're all doctors, and they're all like very close by. So these are names that are very common in my area, and then it becomes a problem where you have names are common, and that is where the second identification becomes important. That's the age. But we still find that that is taken very lightly sometimes. I don't know what is your individual experience, but recording age, I think, is done very carelessly.
Very true.
Ma'am, I think what point you have really said is right because there are identical names in most of the hospitals about the patients. What we follow here is about be very careful enter about the IP number, OP number of the patient in the requisition form. So that will actually drastically brings down the confusion between the two identical names. So
Yes.
most of the time, what happens is because we are surgical department, we have inpatient division. If it, the patient is coming from outpatient division, most of the time they don't enter that outpatient record number. So they just write the patient and they send carelessly. That will go to pathology lab. So when this identical name from another department goes there, that's where the whole confusion starts. So when you have the right OP number, which is already fed in the computer in the main counter, so if any confusion is there, just to type that OP number, you will get all the details. It's a simple thing. It's not, we don't need rocket science to understand this. So, but I feel that this is where even we felt and we come across problems by not entering the details, as you said about the right patient's age, number one. Number two, age of the patient. So number
Yes.
two is OP number or IP number. OP stands for outpatient, IP stands for inpatient. So this is if this can be done correctly, simple things, man. You don't need any scientific brain to understand this. Just to enter the right details and turn to the pathologist, and they'll take care of the rest of the things. Because we face the problems even there too. So I think this is the one of the easiest solution to come across to come out of this problem.
True. So, we have the next question is, what is the best way to prevent skill based errors? So, what I want to ask is, what method you all use, or do you, when newcomers come in, do you actually teach them even these simple things which seem almost logical to know? Uh, but do you actually tell them, or is it a standard to actually tell people that you need to put the right name and how important it is and stuff like that?
Ma'am, I believe that when the trainees come to take up their post-graduation, their specialty education under us, and need to train them correctly, which means to say that if suppose I am taking one case scenario, let us think that oral cancer, there is a region lying in the buccal vestibule. The patient come to the OPD. They really don't know what to do with that. And when the staff are not focused towards them, they try to do whatever things come into their way and perform whatever test they feel like. So we need to educate them exactly how to take the history first based on the chief component of the patient. Most of the time, what I am seeing is people are missing out first in writing the case history. So the moment they see something in the mouth, they think that it is cancer. It can be anything else. So they never, try to get that material out from the patient or patient. How it started, how it is, what kind of problems it is giving, what kind of medication patient is on. Nothing. They just write down, just within two sentences, get to the staff and get a signature done, as you know. So I think how we should
Yes.
train them to write down the proper case history first and duration, everything. Based on that, next investigation, what's supposed to be done? Should supposed to be done an ultrasound or a radiograph or a biopsy or FNEC, things like that. So I believe that we should train the all the trainees first on how to examine the case. So for which you need to have the right mindset at that particular time. If you are totally not having patience or preoccupied with something else, and the lesions like this in the oral cavity, which are little having confusion or life-threatening situations, I think you should take care about your mindset first. Make sure that you are calm enough, you are patient enough to see the patient, and go next to the patient. Wait for some time. Don't hurry up. Don't try to put two mouth minutes in the mouth and try to diagnose and they write something and send the patient out. And most important thing, when in India, what I have seen in our thing is they never ask the patient about the old records. What kind
Yes.
of doctors they have already consulted, what kind of treatments they have received, who referred the case, nothing. So entire past history is masked. They try to start the history based on what they see then. So the history already started, which we miss.
So I think we are jumping into the errors of commission and omission. Yes, into attention and intention. That is true.
That's also,
Yes. So
yeah,
how
that's
to
what I mean.
overcome
So, yeah.
those? Now we already sort of listed quite a few things that could be attention related, or maybe the person is either focused on something else and doesn't remember, or basically doesn't care. When someone is focused on something else, it's obviously, I think, a temporary lapse. and is not likely to be repeated. Still, we need to prevent those. But what if a person is just not bothered? How do you overcome that? Have you ever had that situation, and how do you overcome that?
It's a very tricky question, but
So let's go with
We've all
Professor
come
Jose
across
first.
such incidents.
Sorry, I think I missed a part of the conversation. Right. Uh, so, what were you saying, Dr. Roshan?
I said we've all probably come across this situation where
True.
one technician or doctor doesn't really bother. How do we get over that? Either you retrain that person if possible, or you shift that person out if for temporarily till they get the hang of things and then bring them back. It is difficult, but we all have situations, I'm sure, where
Yes,
there are people who don't want to comply.
definitely. That's very problematic. Any other suggestions?
nothing. But from our side, probably we can educate them and give them and tell
Yes,
them the importance that why they have to behave in front of the patient. Still, if they don't listen, I think probably we should be cautious enough when we are handing over the case to such kind of people. That's it. We should be around what they're doing. That is the only solution. Because once mindset you cannot change. Only thing you can
true.
educate them from our side. If they pick up, then it's fine. If they don't pick up, then what we can do? I mean, it's
So,
very,
basically, we are
it's
down
very,
to increase training, or rather retraining,
yes,
and give them
yes,
more time. And what you said
yes,
earlier, maybe a checklist where a person is
yes,
essentially got to, tick something until
yes,
you accept that it's done. It's something
yes,
like that.
I
But
also
yes.
think that
You have,
yes,
sometimes,
Professor.
yeah, sometimes we think that the people know so obvious things. So we need to say what we think is obvious because sometimes it is not obvious for our team or for our colleagues or for our students. So we always have to set the things we think maybe they are obvious for them or for us. So repeat. That is why I think the checklist or a peer review in processing will
True.
be good for avoiding this kind of errors.
Very true. So, our next question was, what are the common accidental errors observed in the diagnostic procedures that you are overseeing? Anything pops out and comes to mind that is an accident? Basically,
Yeah, yes.
unforeseeable.
I think maybe labeling. Take the sample, make wrong labeling, and mix up the samples.
Yes. I,
Accidental loss of a specimen is
yes.
also something we've seen. It
I'm
either
laughing now,
goes
but
somewhere
believe
else
me, it
or,
was not a matter of laughing some years back. I
yeah,
still
yeah.
recall when I was in Davangiri, one sample left oral surgery and had to come up just 2 floors to reach my department. And in between, it got lost. Nobody even knew it was lost until oral surgery started asking for the report. And then we just could not locate. 3 samples left together, 2 reached, one did not reach. We could not figure out why. And we never could. Of course, then that sample was not recovered. And it was the toughest thing. We had to make a new register, one in oral surgery, one in oral path. When the sample was leaving there, they would enter with who it was leaving. And once it came to us, we would enter who has received it. From who?
receive.
So that was put in place. But it is one of those things that you never really think. I mean, you can't imagine why would a specimen go missing within one building, but it can happen. So this is one of those things. And I think sadly, until it happens to someone, we don't really think about it. And in a way, maybe these events which one doesn't think about is what is good to learn from other people's mistakes rather than wait till we commit it ourselves. But again,
And
we
how
have
do
no
we
way of
avoid that?
sharing those.
And Dr. Mandana, how can we avoid that? Maybe using some sample tracking system. I
Yes,
mean, the
that time we
pathologists
were
have.
very low tech still. This
Uh,
was, I think, around maybe 15, 16 years back. So all we did was we just put in two registers, two notebooks basically to
yeah,
enter. It would be entered as to, where the specimen was being handed to, whoever, pune or student or whoever was going to carry it upstairs to oral pathology. Their name would be entered before actually giving them the sample. Then the sample would be brought to us. We had also a book where we would enter that we received it from so and so person, you know.
yeah.
So
I think you can match both. We are sending
yes,
a sample, and then the lab
yes,
we are receiving that sample. So
that
you match
sample
the tracking
exactly.
system.
Yes. So a record, a log, basically a detailed log of the whole thing. It was almost like in police investigations they have chain of evidence.
Exactly.
So we had the chain of sample. So and we do the same thing for the report also. In those days we were still actually printing and sending, so we would do the same thing.
Yeah, maybe
uh,
we can use technology to help us, like a barcode, something like that.
yes, and I think now more and more hospitals actually have centralized these things. Except for the physical sample that has to travel, there is still no way we can put it into a sample delivery into a you know computer that then gives it out the other end. But otherwise, yes. Okay, so anything else anyone wants to add to the discussion on accidental errors? No? Okay. And
Accidentally putting it in the wrong solution. We have this problem because we get a lot of referrals from outside. So samples come partly for microbiology, partly for us, and sometimes it just comes in saline and not in formalin, and it's 24 hours by the time it arrives. So we have these accidents from time to time, even now. I'm
true.
sorry to say.
Yes, I know. It still happens. That is exactly what I felt and why I felt we should talk about this, because they do happen. They still happen.
Yeah.
And even the numbers tell us that they still happen. Yeah. So coming to our next questions. Okay. I think something. Sorry. Do we have a question? Yes, I think so. Okay. Dr. Vindhya is asking processing machine errors, which they stop in between, and that causes a problem. Yes,
Oh, yeah.
that's true. That is when technology fails on one. So, our next question was risks associated with diagnostic procedures and tests that can compromise patient safety. So, basically, like, uh, radiation, that's an inherent risk. You can't help it. Or for that matter, taking an intravenous blood or a puncture, basically. And a biopsy at the site has some inherent complications and outcomes. So, how do we overcome those? Or what can we do to minimize those?
I also think, Dr. Mandana, that any diagnostic test intrinsically has some false positives and false negatives. So we
Yes,
also have to know that in order to do the correct diagnosis.
diagnosis.
We need to
Yes, that's
consider
also true.
that also.
Very, very true. Yes. So, yeah, so basically, inherent. harm, like as in radiation, or limitations like basic sensitivity, which is not specific, or yeah, or specificity. So those would be, and if we don't know those, now the thing is, we get tests, of course, from clinics. Now, two of you are on the clinical side. How do you expect to get information as to what is the limitation of a certain test or its indications, especially as newer tests keep coming up?
Sorry, could you repeat the question?
Yeah,
Ma'am, your question is about, yeah.
yeah, I'll repeat the question. You know, when we get newer techniques to do things, say in the lab, we get a new machine, or say in the radiology, they get a new equipment. Your immediate department, who you are referring to. So, but finally, we are not the ones writing the test. We depend on the clinicians to write the test. So, you need information, say, from the immediate lab or radiology to tell you that now this new test is available with these new whatever limitations and indications. So, how do you expect, or how would you prefer to, receive that information
From somebody who's
as
already
clinicians?
familiar with as clinician. Okay.
Sorry, no, please tell me, Dr. Roshan, what did
No,
you
I
think
thought
of?
I would like to receive this information from somebody who's got experience with that machine, who already knows the ups and downs or the highs and lows of that machine.
That's for us, yes, when we get new equipment. That is
Yeah,
very
I think
true.
we
The whole
we need to talk with
thing, I
colleagues that
feel,
have more experience with the test or with the machine or with the new technology.
Yes. That communication between the pathology. Now, when I say pathology, I also mean imaging or
Yeah.
radiology. Okay. So, between us, between the testing department and you as the clinician, how best would you like, or you think is the most practical way of getting information?
ma'am, I believe that one should have the right communication between the specialty. Me being a surgeon, cancer, operating with organotic surgeries, all these things. I must have a right the specialties associated with my kind of work. One is definitely a pathologist, like you, radiologist. So the simple answer for this is the healthy communication is the one thing which really gives the best results. Which means to say that when a radiologist gets a new investigation method or the new machine into his lab or the pathology, they should inform to the surgeon is what we procured for our lab. So this advantage of this particular machine or the test is so important. If you have cases like so let you refer the case to us and we will see this how it is going to work out. For example, I think about 1 year back here CT MRI machine together. Earlier MRI was different, CT was different. Done in one particular one go kind of diagnostic. So that they we on this. So after that resolution on that initial
Shivani, I think your voice is
case.
breaking quite a bit.
Uh,
Yes, yes,
can you hear me, ma'am? Now
It keeps breaking.
hear me? I
Just
think some
speak now.
network issue. I think.
Yeah, maybe network issue.
Can you hear me now?
Yeah, I
Net
can
issue.
hear you.
yes.
You
Can you
can
hear me
turn
now,
off
ma'am?
your camera and see whether that will help.
Camera.
Yeah, just turn off your camera. There's the camera sign below. If you just click on it, it will disable your camera.
Then I should speak.
Yeah, then you can speak because I think internet issue is there. Yeah, just try now.
No. No.
Can you
Can you
speak?
hear me?
Yeah, we can hear you,
Am I
but
Yes,
it's
audible?
still
Patrick,
breaking.
was. It's
Um,
worse now.
Someone else can talk in that case. A
Yeah, it's a network problem, I think. Is there any other network you
network
can
issue, ma'am.
try?
No, I'm on Wi-Fi actually. You know.
Okay, right. Okay, never mind. Yeah, continue.
Can you hear me now?
Yeah, we hear you, but it breaks in between.
Something happening here also. Your voice was the break. I'm
Okay,
having that
then
issue.
it's
Maybe
a
network
network issue at your side. Yeah,
issue. I think.
no, it's a network issue.
Yeah, yeah, definitely.
Okay,
I
let's
think
take
I
some
in one
more
sentence. Probably I
questions
think
and then,
combination
yeah, tell
between
me.
the specialists. Yeah,
Yeah, please go on.
between the specialists problem.
Yes, you're right. Communication is the
Can you hear me,
essential
ma'am?
part.
Now?
Yes,
Yes, yes, yes, yes. Nobody should have another. Everyone has their limitations, but I accept that. And probably it is a work.
yes.
Everyone has that importance, that particular, role.
Okay,
And need to
let's
update
do
ourselves
this.
and also among ourselves.
True. Communication is important. In fact, while we are on the matter of communication, uh, you know, the main thing that happens today about patient safety, or the main dialogue around patient safety, is relating with
Yes,
informing patients.
yes,
Now, we know certain things have basic risks. Like if you do a biopsy, there is a risk involved, which, and not only a risk, in fact, there are certain expected outcomes. So, how do you think we should inform the patient about these?
I think we need to have a transparent communication with the patient, and
Yes.
we need to know that the patient understand what we are saying, and that doesn't have any doubts, and also maybe sign that informed consent procedures,
Yes.
so legally we could be protected. But I think the most important thing is to have a transparent communication with patients. Always be honest, saying the risk that may happen, not that they would happen, but they may happen,
It happened.
so the patient can have confidence with us.
True. But I think certain risks are inherent, aren't they? For example,
Yes,
if you are going to incise into a salivary gland, or
yeah,
incise a salivary gland, in the minor salivary gland, there's a part of the risk that is inevitable. It's not, it might or might not happen.
yeah. And you should tell
Hmm.
that to the patient. I mean, bleeding
Exactly.
risk, infection risk, pain.
Yes, exactly. Right.
I always taught my students that we have to tell the patient the worst case scenario.
Yes.
So the
The worst
patient,
case scenario.
yeah, so
Very
the
true.
patient will know that some things may happen.
May happen. That's true. Yes. Okay, let's take a question and then we can come back to this. Right. Professor Hill says wrong orientation, cutting, embedding of mucosal biopsy tissue and missing the epithelium is same with fresh tissue or frozen section where it is in DIF. Yeah, to do DIF. Yes. These are all, what would we say, skill based. They can be both skill and they could also be basically carelessness, where you have the skill but are not focused enough to do it.
I think it's both skill and focus.
Yes. So, anything, let me see what does Dr. Subot. One of the biggest problems of OMFS face is lack of oral pathology service. Actually, in India, there are lots of us, so I don't think our surgeons have that problem. What do you think, Dr. Shubharni? But other countries, I think there is a
Probably I
problem.
think
Yeah.
where Dr. Subodh is working, he has a little
Yes,
more.
he is in the US. Yes. I don't know what's the situation
Like
in South America.
maybe there is the lack of overall.
Sorry, Dr. Shubharni, you were saying something, it broke.
We'll move to the next question now.
Yeah, okay. Um, no, I was also asking,
Communication and
uh,
healthy.
okay. Um, so does anybody else, I mean, to anybody else's experience, either in the audience or here, Professor Jose is there, do you think there is a problem with the number of oral pathologists? Access to oral pathology service?
Well, I think we have a
Yes,
lot of pathologists here in Brazil that who works at the universities. So universities sometimes do that kind of analysis, but also outside of university we have some pathology labs. But sometimes the specimens is analyzed by medical pathologists, and the test result came with a different description.
Yes,
And
that's
if the surgeon or if the oral medicine specialist is not well trained, uh, he or she can have some difficulties to understand or to interpret the results.
that is true. Yeah, we normally have that. I think Dr. Roshan also will agree. There's where it comes to mostly odontogenic lesions and lesions related to the infections or dental caries
that's true.
subsequent to dental caries. It's easier when oral pathologists are reporting it. I don't know. I hope I'm not overstepping, Dr. Roshan. You can also, because she is a general
No,
pathologist.
yeah,
Yes,
uh, I personally feel we don't have enough oral pathologists in Mumbai. We need more because it's the commonest problem in India to have oral or cancers of the oral cavity, and we don't have enough people. And we get a lot of referrals with different types of descriptions and diagnosis. So it makes me feel that oral pathology requires like extra training in at least in India. I don't know how it is in South India, but in my part of the city, it's not commonly approached rationally. I shouldn't say that, but there are problems when they refer material to, let's say, to a center like Tata Memorial or any higher center, then there is a lot of discrepancy, which shows us that oral pathology is not taught that well.
true. I think actually, many centers do not really employ an oral pathologist in their pathology
Yes,
team. And that is
that's
the
true.
problem. Especially tertiary centers should
Yes,
have the oral pathologist, but they don't still. That's something we are fighting for.
very true.
Yes, and
But
also I think the general
yeah,
pathologist doesn't have enough training in neuropathology, so
yes.
that's
Yes,
complicated a little bit when you use those kind of laboratories.
No, you know what happens? I think pathologists study the whole body in 3 years. What we study only the maxillofacial in as
yes,
much time.
Yeah.
that's true.
So that's the thing. Right? Okay. Professor Hill. Yeah. Wrong orientation come. Oh, this I've gone through. So sorry, sorry. So Dr. Vindya, in our hospital, we get emails regarding new tests, types of samples, and turnaround time. Yes, that's a good way to inform all the departments, I guess. And yes, unsupervised cutting up by junior technologists is a source of error in oral histopathology. Very good point. But I think unsupervised work by juniors is a source of error everywhere. I mean,
Yes, true.
definitely in oral pathology, but everywhere else too.
Right.
Yes. And by the way, feel free to jump in and comment on any of the questions. So, most of the oral pathologists in India are doing GP rather than practicing OP. And not entirely, but what I would say is most oral pathologists in India are working within colleges. So, we have become a very institutional branch, and not many are available outside. That is the thing. That is what we are trying to overcome now. Okay. And yes,
Also, I don't know how it is in India, but maybe a neuropathologist outside the universities who could not or would not be well paid for doing the analysis. I mean,
true. As a whole, I
how much
think
can you charge for the analysis?
pathologists are generally not the best paid, and we follow the standard and we follow the same thing.
Yeah,
But in India, what happens is a lot of doctors, a lot of dentists, a lot of oral surgeons, and oral medicine specialists are practicing independently and individually. So they do not want to send their samples necessarily to a college, you know. So, which is why we need to have oral pathologists also independently
outside.
supporting that
Yeah,
group which
good.
is not attached. Yeah, and that is lacking. There are
Mhm.
enough pathologists working outside, but not enough oral pathologists. So, I think we've gone through most of the questions. Let me see what we have left. So we have generally gone through things which were a part of the questions, the limitations, the miscommunications. Right. So we'll just at the end, what in your experience is successful practice or approach that has proven effective in overcoming patient safety concerns, and how you would suggest that those be implemented in other centers? Yes. Anything?
I think we inside our institution standardize protocols, so we can follow up those protocols. And regarding with the patient, I think educate the patient and have very open communication with them, providing probably written material for the patient in order them to understand what we are telling them, and involving the patient on decision making after they have the diagnosis. I think that is also important. Uh,
Right.
maybe maybe that's some idea that I have right now.
Good. Anything else, Dr. Roshan?
Right. Following protocols, SOPs, attending conferences which are targeted to oral pathologies, especially if you're working in an oral pathology center, people should know you exist so that they can refer material when they have problems.
True.
If they trust us, they send. They will not
That
send
is
to a
very true.
general pathologist. They will send to an oral pathologist.
Correct. If people can't find us, how can they send anything to us? That is true.
That's right.
Yes. And Dr. Shivbarni, anything?
But that's what man said is because certain oral pathologists should come forward and make sure that they have a platform even apart from colleges where they are working, and they should be approachable because most of the suppose if you take the ET specialty, even they operate about oral tumors. friends in ENT specialty. I have many friends in other specialties. So they never send the specimen to the oral pathologist. They never. Most of the people don't even know that there is a branch existing called oral pathology on this
So
side.
true.
I'm talking about surgeons of ENT and ophthalmology, general surgery, these things. So what is this? Not anybody's personal mistake, ma'am. It is something like they are not coming forward. I believe they're not putting the kind of extra efforts to make sure the specialty stands apart from the general pathology, where they are best in diagnosing hereditary tumors. I think that's what probably I think the entire association of oral pathology should work out. It was the same even for my specialty also way back 20 years ago. So over a period of time, my senior colleagues and people, they have put a lot of efforts. Now, the fellowships for even maxillary surgeons, even for Tata Memorial, Kidwai and Bangalore, it's all officially started by government as well as from the association, which was never there when I did my master's in way back in Harvard. So now, because a lot of my seniors, my teachers, that generation have put a lot of efforts and made sure that what is this specialty meant for. So that's when now we get a lot of cases. As you know, when you're working down here, how many cases I used to get from the medical side to here? A lot of these tumors of oral cavity. We used to operate left, right, center in those days. So that's not because of not my own efforts. It's because of the entire association, what the efforts they put it in this. And now that mark has made. I think probably, and all the side, people should come forward like this and make sure that they make a benchmark out of. Uh, then I think
Yes.
definitely they would be. I mean, this is. I'm not targeting anything. I mean, I think I hope you understand what I say. This
No,
is,
no,
this is
that's
how it should
perfectly
be.
all right. No, I get it. But I think at the end of the day, in this discussion, which was about safety, it's an interesting thing to find out that at some level, uh, if we are not available, or if the right branch or the people with the right expertise are not easily available to our colleagues and to the patients, then in some way we are again adding errors
Yes.
indirectly.
Yes.
But nonetheless,
Yes.
this was an interesting part I had not foreseen as a part of this discussion. But it is
Ma'am, I
interesting, yes.
believe I would like to add in a point. I believe that ma'am, every clinician should have some compassion, empathy towards the patient. Because
Yes.
when they come with a non-healing ulcer in the mouth, which is more or less to be cancer case, their days are numbered. Their life is kind of shortened. The expectancy of the oral cancer in India presently how it is. So one should have that empathy. One should have the compassion towards the patient's disease and patient's suffering. It's not that you are treating the tumor by doing operating, by doing chemotherapy, radiotherapy, or pathology. It is that you are handling the emotions of the patient. The patient, because the patient cannot accept that he has cancer in the mouth. It's very difficult for anybody to accept that he has
Yes.
cancer. So 70% of his life falls off then and there itself. But the moment they know that that emotional draining is something that which is not good for the patient. Probably as a
That's true.
clinician, we should first boost up the patient's confidence, give up the warmth and
That's
love
true.
and affection to the patient, then talk to them. Then
Interestingly, we have this is actually the third lecture or the third event in that
yes,
series. The first
yeah,
we had was on empathy, and the
yes.
next one was on breaking bad news, how to break bad
Oh, sorry.
news. And
Yes,
this is
yes,
the
yes.
third one, which is on patient safety.
Okay, okay,
Sort of
okay. Right, right.
a combination of three, that for general skills and general things that are important. So, to
Right.
sum up discussion on patient safety, I think we came up across certain points that still clearly say, besides the numbers that I read in the beginning, is that there is still lots of possibility for errors in the diagnostic cycle, and it is all avoidable. This is all avoidable, especially
Yes.
since we are not making emergency or last minute on the spot decision. This is not the emergency room. We have the time to think, to have a SOP, have people actually look at a list, maybe check whatever they are doing. So there's still a lot more. And from the little bit available, I think it is very clear that much more work needs to be done. To wrap up, just a 30-second from each of you. Your personal choice. Which one thing? you think should be a focus for the next few years? Your top of the list as far as
I think the
patient
right way of
safety goes.
examining the
Yes.
yeah right way of examining the patient. For example, if the patient comes with a lump in the cheek or maybe lump in the neck, don't try to stick in the needle directly inside. And just think that it can be vascular tumor. It can cause disasters once you put it in. I think probably everything goes funnels down. I think probably with the history of the patient. So
Yes.
once you don't concentrate on history of the patient, probably I think 50 to 60% of the points which is supposed to be right will go wrong. So patient's examination and right mindset when you're examining the patient, empathy towards the patient, and invest the time with the patient, not in hurry worry that do something and get out of the place. And these are a few things probably because madam, most of the tumors in the oral cavity needs one light and two mouth mirrors. That's it. Nothing beyond that. At least is either some answer in the mouth. Even that, if you are not in a position to see, it is a paradox. So I believe that one should have that kind of mindset to when you go to the patient, when they come with a lot of pain, and see that, spend some time with them, examine, then come to the conclusion that what kind of diagnostic method
Yes.
you try to implement. I think that is what is the first and foremost step which we have to
So the
follow.
appropriate patient history and
Yes,
decision
yes,
making in
yes,
choosing the
yes,
test.
yes, ma'am.
Yes.
Because the rest of the technology is available. Right from your
Yes.
simple radiograph to PET scan, everything is available in the market. We can, it's like one shop, we can do it anytime. But only thing is, what to do is the question now. Not how to
True.
do, what to do is the question.
What to do is the
So that
question.
needs probably, yeah, yeah. So we need to have right history and for which we should have patience first with patients. You go and examine the case.
That's true. Yes.
Yeah, that's how I think that's
So,
what.
okay, let's
I
go,
agree
Professor.
a hundred
Yes.
percent with Professor Shiva, and I said that maybe the word will be empathy.
Yes,
Put put ourselves in the place of the patient. So that will
yes, exactly.
that will mean that we have to do a correct data entry, correct sample manipulation, taking care of the patient, give him or her the news with empathy, making the right choices with them. So, in one word, empathy with patients.
Empathy. Okay, so Dr. Shiva sort of covered in the pre-analytical stage. You have covered the post-analytical, interacting with patients. So, Dr. Roshan, I think the analytical is left for you.
You know, it's good to talk to patients. It's absolutely essential. But we need to talk to our doctors too, like to our surgeon or to our radiologist or, the technician. We need to talk in the medical field to, to understand their problems. And then we give our point of view. So if we don't talk to enough to our technicians or to our colleagues, then we are in the dark. We are always sitting in our ivory tower alone. So these joint clinics are very useful. We learn a lot from a joint clinic if it's conducted periodically for even for simple cases. So I feel, of course, you need to talk to your patient and give compassion and empathy, but we need the compassion and empathy for our colleagues also. Sometimes we forget our colleagues.
Very true. And it really makes a difference. I mean, I can
Yeah,
actually say this from when I was working in COTS, from the time Dr. Shubharni took over and headed oral surgery, and we had a good interaction with oral surgery. I think definitely I can say that our work in oral pathology became much easier and much better,
yeah.
you know,
More interesting.
and more interesting. Exactly. We could discuss so
Yeah,
many things, and that understanding made it so much easier. And at the end, finally, that helps the patient.
right, right.
Exactly, ma'am. The receiving end is the patient. When that is the target, everything goes correctly.
Correct. Yes. Okay, let me just
But I
highlight
think
that.
Madhushankari ma'am has put a message there.
Yeah, I'm just seeing, I'm just seeing
Madhushankari,
that. Okay, let me show that. Yes, Dr. Madhu is now heading the department in COTS. Hello, everyone, ma'am. I feel practicing oral pathologists, so as such, are less. Otherwise, oral pathologists are there in great numbers. Yes, I know. At least in India. Um, just for everyone's information, we may be around 4,000 of us in India. We are the largest oral pathology fraternity in the world.
Oh, wow. I didn't know
I
that.
know it doesn't seem like.
Yeah.
That's why
Yes, I
rightly
know.
ma'am has put a message there. Yeah.
Yes. We are sort of well hidden. We are trying to get out now and be noticed. Okay, so this was a very, very interesting discussion. Thank you all. I know it was not a
Thank you very
topic
much.
that there was much material on that one could go with. But I think as long as we summarize and come to the conclusion that we are not done with patient safety, it is not done and dusted. It's still very relevant. Every bit of it is important, and we need to still keep working on it, even in diagnostics, so that
Thank you very
uh,
much.
you're
You'll
most welcome.
excuse me,
Thank
please.
you. I should say thank
There's a
you.
frozen section.
Yes, please go ahead. Please go ahead. So, near the end of War and Peace, Tolstoy wrote of one of his main characters that he survived in spite of being treated by doctors. So let's hope that as time goes by, that is never the case again. And nobody can ever say that somebody survived in spite of being treated. Let's hope all treatment ends well. Thank you
Let's
all
hope
so
it is
much.
so.
But please wait.
Thank you, ma'am.
I do have to share your
Yeah,
certificates. Yes, thank
Thank
you
you very
so,
much.
so much.
yeah.
Uh,
Don't give it for
Thank you.
no.
great, great session. Thank you.
Hyperplastic
I do
without
hope
Thank
we
you
will
so
anything.
much.
have all of you again over.
Thank you very much.
Certainly.
Thank you very
Thank you,
much,
ma'am.
Vandana.
Thank you.
Thank
Sorry.
you.
Thank you.
Bye.
Bye
No, that's
bye. Thank
okay.
you very much.
Bye. Yes, thank you.
Okay.
And
Okay.
to
Hyperplastic
continue
follow.
with, sorry, uh, what is going to be next week? We are going to have Professor Daniel Goldenberg. He's going to talk about careers in research in Brazil. Do join us. This will be interesting. With that, let me say bye to everybody. Have a wonderful week. See you here again next week.